Good evening, everybody. I would like to thank Dr. Arjun Kalyanpur for giving me this opportunity. And hello to all my colleagues at Teleradiology Solutions. I hope my students from Satisai are listening to me, so my special hi to you all. So let me start my talk today. The topic for today is imaging in acute stroke, recent trends and recommendations. Now, this is a very important topic because year 2015 has marked a special point in the history of stroke, especially imaging as well as its management. And I'll let you know how it is so important. So, to begin with, disability worldwide, and it is considered as the third largest cause of death worldwide. And what happens in stroke is, now I will be speaking about ischemic stroke. So what happens is there is a vascular compromise. It could be because of a thrombus or embolus. And then slowly the dynamic process of the stroke starts, leading to neuronal death and dysfunction. And believe me, it's a very quick process. So what are the basic categories of stroke? As I said, it's basically classified as hemorrhagic and ischemic. Hemorrhage constitutes 20% of these strokes, acute strokes, which I wouldn't be covering today. It is usually because of hypertensive hemorrhage, and you know that common location is generally putamen followed by lobar areas. The common type of acute stroke is ischemic, which accounts for 80%, and out of that, thrombotic stroke, that is because of an intracerebral atherosclerosis, that is the stenosis is within the vessels of the brain. Is the cause of stroke in 40% of the cases, and majority, that is 60% of the cases of stroke, happens because of an embolic phenomenon. That means the thrombus travels from some remote area, comes and blocks the vessels of the brain, and these could be from the cardiac embolus. Now, I work at a stroke center, and I have seen that mostly these stroke causes come from the clot when it's dislodged from the heart, and in case of atrial fibrillation, that's a very common clinical setting what we see. It could be because of artery to artery embolism, that is when there is a clot at the neck and generally at the carotid bifurcation, and it lodges up and blocks one of the major arteries. Or it could be because of some paradoxical embolus like fat in case of trauma. So what happens in stroke is, as I said, it's a dynamic process. So as a vascular compromise occurs, it has to be acute. That means it is not because of a slowly developing over chronic occlusion of a vessel. It is acute. So that means a vessel which was nice, open, supplying a part of the brain suddenly gets occluded. What happens? That means the cerebral blood flow reduces. So as it comes down, you will see that the function of the neurons also come down. And it is a very quick process. So it starts from reduction of evoked potential, then suppression of evoked potential, there's disturbance of tissue water content, and because of that, water gets collected within the intracellular component that causes cytotoxic edema, and that causes increase in the extracellular potassium. And finally, when the cerebral blood flow comes down to 6, the increase of cortical impedance occurs, and that causes death of the neurons. So when I said about cerebral blood flow, what is a normal cerebral blood flow? The human brain receives around 50 to 60 ml of blood per 100 gram tissue per minute. This is the normal range of the cerebral blood flow. This is for the gray matter. What happens when the cerebral blood flow reduces, that is below 50, ischemia develops. And at this stage, still the brain has the capacity to revive or to open up or to recanalize. And so what happens is the cerebral autoregulation takes place. What is cerebral auto? That means any situation when the brain has to face a sudden change in its atmosphere, maybe because of sudden blood flow loss or sudden hemorrhage or hypertension, what happens is the cerebral autoregulation, the vessels of the brain, they try to compromise for this and still try to keep the blood flowing to the brain. And that is because of vasodilatation, because of opening of various collaterals. It also causes increased extraction of glucose and oxygen. And so at this stage, still the brain is alive, and it is just trying its maximum capacity to keep its metabolism going. But when the cerebral blood flow goes below 20 ml per 100 gram per minute, it is at that time an electrical silence ensues. That is what I said is the cortical impedance increases. And when it goes down below 10, that is where the irreversible neuronal injury occurs. So this is how the cerebral blood flow will characterize the stage of the neuronal dysfunction. So what happens is, in a typical acute ischemic stroke, every minute the brain loses 1.9 million neurons, 14 billion synapses, and 7.5 miles of myelinated fibers. This is very, very significant. That means time lost is brain lost. So that is why to identify a clinical ischemic stroke and to do the imaging, to have a correct protocol in place, to diagnose, to interpret, and to send the patient for immediate treatment is very, very important. And imaging plays a very important role in this. So whenever we speak of ischemia for an acute ischemic stroke, there is a concept of ischemic core and penumbra. What do you mean by ischemic core? This is the central, as you see, this is like an imaginative diagrammatic representation of a cut slice, axial slice of the brain. And you can see the circle of Willis here. On the left side, the ICA is dividing into the ACA and MCA, that is the middle cerebral artery. We have a clot sitting in the left middle cerebral artery. And this causes sudden, central, irreversibly infarcted tissue core, and then surrounding is a peripheral region of stunned cells called a penumbra. Because as soon as there is an occlusion to the vessel, the central area of the entire territory is the first most vulnerable to ischemic event, because it is not ready to prepare itself for the autoregulation or vasodilatation, and it just immediately dies. This could be small in the initial stages, and slowly it starts increasing. However, the tissue at risk, that is the penumbra, is the region. If we do not address this issue, if we do not open this vessel, even the entire penumbra is at risk of undergoing core infarction. And it is this penumbra which we are intending to save. So the entire idea of stroke treatment revolves around saving this penumbra, that is not allowing the core to increase in size to cover the penumbra. So if you see, this is a mismatch, that is the penumbra minus the dead tissue is the area where we are interested to save. So it is a potentially salvageable area, because as I said, the cerebral blood flow is still hanging on somewhere around 20 to 50 with maximum vasodilatation or collaterals opening up to supply this brain. But with time, even that will give way. So we have to save this penumbra. So what are the factors which affect this progress of ischemic stroke? One is the rate of onset and the duration of the occlusion. The rate of onset, if it is a sudden occlusion, obviously it will affect the most, because the vessel is not prepared for it. Imagine a vessel which was slowly occluding, that is, there is a atherosclerosis there, and slowly the vessel starts narrowing. So it gives the brain enough time for the cerebral reserve to develop, so that the brain, because of the cerebral autoregulation, still tries to get supply from the dilated collaterals in the periphery, from pile or dural collaterals, and this keeps the brain prepared for an acute stroke. So in case of chronic occlusion, it is less disastrous as compared to acute occlusion. So the rate of occlusion is a very important factor. And the duration of occlusion, that means how long is the vessel occluded. If a vessel is occluded for only a few minutes and it recanalizes, either because of a medical therapy given or because of an endovascular treatment where the clot is pulled out, the brain still has chances of reviving itself. So however, if it's a longer duration of occlusion, as I said, the core increases in size and the penumbra decreases in size, the potential area of its being revived is less. And obviously, the most important factor affecting the progress is the collateral circulation. And of late, collateral circulation is considered as a very important point of research going on all around the world, where people are trying to characterize the collateral circulation and trying to prognosticate based on that, like which patients are going to survive or which patients are going to have a bigger infarct. and the status of systemic circulation. This means the level of blood pressure and other issues like cardiac function. All these factors also affect the progress of the stroke, and also to some extent hematological factors like blood hypercoagulability and such situations keep clotting the blood, and so even if you try to open up the vessel, if the hematological factors are not really favoring, then patient might have a hemorrhage. So these are the factors affecting the progress of ischemic stroke. These are very important to understand before we move into the imaging. So what has changed in 2015 about the paradigm of stroke management? It's the 5 recent clinical stroke trials which have just published and declared positive during this year, and this has been going on since a couple of years, these type of trials all around the world. The most important 5 trials for all the DNB students to at least mention if it comes in the question paper is Mr. Clean. This was done at Netherlands. This was a multi-center randomized clinical trial of endovascular treatment of acute ischemic stroke. Escape. This is the study which was carried out at my center in Canada, where endovascular treatment of small core anterior circulation proximal occlusion with emphasis on minimizing CT to recanalization time. That is Escape. And the other 3 important studies to be worth mentioning are SWIFT Prime, Extend IA, and REVASCAT. So these are the 5 important clinical stroke trials which have changed the paradigm of stroke management. What is the basic gist behind it? It is that first you have to select the suitable patients. It's all about emphasis on endovascular treatment. That means if there is an occlusion, vascular occlusion, you have to go and pull out the clot and revive the penumbra region, right? So all these trials have utilized imaging as the most important clinical tool, or imaging the selection tool for picking up suitable patients for endovascular treatment. So before these trials, the emphasis of treatment of ischemic stroke was more on intravenous thrombolysis. That means if a patient presents within 4.5 hours of acute onset of stroke, if a patient presents, and if the CT does not show hemorrhage, these patients were basically considered as eligible for getting intravenous TPA, that is tissue thromboplastin, tissue plasminogen activator. But nowadays, this paradigm has shifted, and it is more in favor of endovascular treatment if they are considered eligible. So what are the major conclusions for these trials? The first thing was the fast reperfusion, or faster the reperfusion, better the outcome. So here comes the important analogy of time is brain. So they emphasized on faster reperfusion. And they also emphasize on endovascular treatment, especially using stent retrievers. What are stent retrievers? They are basically devices with stents at the end of it, and it is carried all the way into the site of clot, and it is deployed. It engages the clot, and then the stent is retrieved back. So it actually carries back the clot. And it was considered as a very safe and effective way of treatment. And most importantly, imaging plays a critical role in patient selection for endovascular therapy. So it is this imaging what we are going to speak about. So what is the role of imaging for selecting the patient for this suitable therapy? First is to rule out hemorrhage, to rule out large infarct cause. Why is it important? That means if a patient already has developed an established large infarct, there is really no meaning in going up and opening that vessel. It actually puts the brain tissue to a risk of hemorrhagic transformation. As you can imagine, when a brain tissue is dead in a region of interest, the vessels are already at this maximum vasodilatation, and the cerebral regulation is out of the way. It is not working, and the tissue is like leaking. There is loss of blood-brain barrier. At that situation, if you open up the vessel suddenly, the blood will gush into the dead brain tissue, and it will cause a large hemorrhagic transformation, and that is considered as more devastating than even the ischemic area. So it's very important that you have to rule out a large infarct core. If you notice large, well-established infarct, there is no point in going and opening it up. So imaging plays again an important role. And to treat these patients, treat the patients who have proximal occlusion. Proximal occlusions means when you see a clot sitting in the internal carotid artery, or the first segment of the middle cerebral artery, or the first segment of anterior cerebral artery. I'm speaking only about anterior circulation because posterior circulation stroke, they are less in number, they're rare, and also there is still not a defined paradigm for treatment of posterior circulation strokes. So we are speaking all about anterior circulation strokes. So you have to pick up the patients who have these proximal occlusions because these are amenable to endovascular techniques. Then to quantify the collateral, as I said, collateral imaging, collaterals are very important in prognosticating the progress of ischemic stroke. Imaging plays an important role in quantifying the collateral status, and also CT angiogram gives us a very good idea about the vascular anatomy, and so the endovascular treatment can be planned based on the CT angiograms. These are the basic important roles of imaging in stroke. I see somebody has raised his hand. Is there a question? Or maybe at the end of the talk we can share, we can have some chat. So role of CT in acute stroke. What does CT do now? There are various imaging modalities in acute stroke. It can be CT, MRI, angiography. So most importantly, when a patient comes to your hospital and presents with acute stroke, initially the patient is assessed clinically to rule out stroke mimics, be seizures or something, and as soon as it is diagnosed as acute stroke, patient is rushed to the CT scanner to perform a non-contrast CT. And to be noted is that all these recent trials, the 5 recent trials which I spoke about, they used non-contrast CT as a first line of imaging for patient selection. So it is beyond doubt that a patient with acute stroke has to be imaged with non-contrast CT. Why? First, to rule out hemorrhage. So because patients with acute stroke will have almost similar presentation when it is ischemic or hemorrhagic. So it is difficult sometimes to clinically point out. Very important to rule out hemorrhage and to look for signs of early ischemic changes or signs of acute stroke. Now these are the commonly described signs of early ischemic changes which you all must be aware of. They are the hyperdense vessel sign, insular ribbon sign, obscuration of lentiform nucleus. What is hyperdense sign? That means an acute thrombus in an intracranial vessel typically appears hyperdense. So it is almost like it is highly specific but not always sensitive. I mean, you may not be able to pick up a thrombus every time, but if you see, it is highly specific. So a clot within a vessel on a non-contrast CT appears hyperdense. What are the limitations? With patients with high hematocrit level, where all the vessels will just appear hyperdense and it is difficult to comment on that, and they are usually bilateral. Or when a vessel has calcification, like a middle cerebral artery calcification, which is just hyperdense. So sometimes HE values help. If it is in the range of calcification, then it's ruled out. So it is difficult. And rarely fat embolus, which is very rare event, can appear hypoattenuated as compared to the contralateral vessel. So these are the common limitations. However, hyperdense sign is considered as an important sign. How does it look? On this non-contrast CT, you can see that the right MCA, the right M1 segment, is appearing hyperdense as compared to the basilar artery and the contralateral MCA. This is the hyperdense vessel sign, very sensitive, very specific for acute ischemic stroke. Insular ribbon sign is the hypoattenuation of the insular cortex, as you can see on the left side, clearly demarcated by the white arrows here. This you compare with the contralateral insular cortex. Now the cortex on CT scan has to appear brighter than the white matter. So when that when the bright density is lost and it almost merges with the hypodensity of the external capsule, that is what we call it as an insular ribbon sign. It's like a band of hypodensity, and this can be picked up quite early. So always in a case of acute ischemic stroke, look for the insular ribbon sign, compare it with the opposite side. This is a very specific sign of MCA occlusion. And most importantly, even obscuration of lentiform nucleus is also a very important early sign of acute ischemic stroke, which can be easily missed unless looked for. So if you see that this is the normal outline of the lentiform nucleus, the lens-shaped basal ganglia structure on the right side. If you see on the left side, it is completely obscured. That means the entire base, the lentiform nucleus is hypodense now, and the margins with the internal capsule and external capsule is lost, and this causes obscuration of the lentiform nucleus, a very important sign of early ischemic stroke because of occlusion of NCA. An important point which is worth mentioning here is about the aspect scoring. That is the Alberta Stroke Program Early CT Score, and this is widely used all over the world for quantification of the extent of stroke. So this is like a 10-point scoring system to quantify acute ischemia on a non-contract CT based upon the degree of involvement of the NCA territory. So the point to be noted is that it is only for NCA territory and not for any other territory, because it is the commonest cause of acute ischemic stroke. So basically on axial CT scan of the head at the level of basal ganglia and higher up at the level of the central semiovale. These are the two cuts which we generally take to quantify or to give the aspect scoring. Basically, the NCA territory is divided into 10 regions and given score of 1 to each. That means the first region is the insula, then the frontal operculum, M1, and then the temporal lobe, anterior temporal pole is M2, and posterior temporal region is M3. So insula, M1, M2, M3. At the level of basal ganglia, you have 3 points: caudate, lentiform, and internal capsule. So these are 1, 2, 3, 4, 5, 6, 7. So seven score at the level of the basal ganglia, and 3 more score at the level higher than that. That is, anteriorly the frontal area is M4, then the frontoparietal region is M5, and the parietal region is M6. So these are arbitrarily given these numbers and a score of 1. Now it is not a very still not a very straightforward classification, because you really don't have a demarcation between M4 and M5. However, it is like arbitrarily given. So the aspect system divides the NCA territory into 10 regions, and so if you see the level of involvement of any of these regions, you have to basically deduct a point from each region. So a normal NCA territory will receive a score of 10. That means all the regions would be normal in attenuation. And if there is a diffuse NCA involvement, that is all the 10 regions are appearing hypodense or showing signs of early infarct, then it will receive a score of 0. It is all the points deducted. The lower the scores, worse is the stroke severity, and higher the risk of symptomatic hemorrhage. And we have seen that this baseline aspect score correlates well with the stroke severity scale, and as the aspect decreases, the probability of dependence, death, and symptomatic hemorrhage increases. So this technique requires performing high quality non-contrast CT with good SNR and visualizing the images at appropriate window width and levels. Now the team of Aspect who have developed this scoring system have recommended a window width of 50 and a window length of 30 as a good starting point to basically to look at the areas of stroke involvement. And there is a site, www.aspectinstroke.com. I would recommend all the residents to once visit this site and do some practice, and they have given all the more details about aspect scoring. It's a very important, and if you understand this once, it will be easy for you to interpret acute stroke. Now this is an example of aspect scoring. A patient has presented with acute ischemic stroke with right-sided hemiplegia. This is the window width which I was speaking about, window levels, and So you can see the insular ribbon sign on the left side. To make it easier, I have put the arrow for you. If you notice the lentiform nucleus, it is not obscured. You can make all the margins of the lentiform nucleus, it's not involved. And there is also subtle hypodensity of the caudate. So there are 2 areas involved. So just deduct 2 from 10. So the aspect score is 8. An aspect score of 7 or more are considered good, and the chances of hemorrhagic transformation is less. So this is a good sign. Now in this region, this is an example where you see this was the patient who presented with left-sided hemiplegia, and you can see that the infarct is quite significantly set in. There is areas of hypodensities. They're very subtle, so you have to make the right window adjustment to pick them up. So almost all 5 areas like M1, insula, M2, M5, and M6. 5 areas are showing this hypodensity, and so 10 minus 5, the aspect score is 5, which is a poor aspect score. And such patients should not be taken for treatment, because if you open up the vessel, they are going to have devastating hemorrhagic transformation. The same patient on 24-hour follow-up, you can see well-established infarcts at the regions what I had mentioned earlier. There is another scoring system, BASIS, which is not commonly used. It is the aspect scoring system which you have to basically understand better. This BASIS was done at Boston. So this is Boston Acute Stroke Imaging Scale. This is not very does not use a clear-cut demarcation. So it basically just says that it considers the arch vessel occlusion along with the parenchymal changes to classify it into major and minor stroke. So as per the BASIS, they say that large vessel occlusion or significant ischemic changes are classified as major stroke. So it is not very helpful for us to classify the stroke. So that was all about the non-contrast CT. I hope that has helped you. Now coming to CT angiography, this is the second most important mode of imaging tool for selecting the patients for endovascular therapy. So CT angiogram can diagnose occlusions of large intracranial vessels with a very high sensitivity and specificity, and diagnoses 100% of all the proximal occlusions, as I said, ICA, MCA, basilar artery. And as I had mentioned earlier, MCA occlusion is the most common cause of cerebral infarction. The CT angiogram is a very important tool for picking up these occlusions. This is an example of, these are like MIP images of the axial CT angiogram, where you can see there is acute abrupt occlusion of the left MCA, M1 segment. In this example, I'm showing you, this is the posterior circulation, posterior cerebral artery. This is the P2 segment, and there is an abrupt occlusion here. Basically, reading a CT angiogram is very important. You just have to keep tracing the vessel up down. It is something similar to how you do it for the pulmonary embolism. You should know the anatomy of the vessel. You should know the expected course of the vessel. Keep tracking them, and when you see an abrupt occlusion, abrupt cutting a vessel, that's the level of the occlusion. So it's very important to trace the vessel up and down and look at the course of the vessel. These are examples of distal occlusions in the M2, M3 levels, which have been picked up on CT angiograms. So nowadays we are getting good quality CT angiograms. So we are not really expected to go quite distal at M4 level, M3 level to pick up the occlusions. At least, most important, at least at the level of the residency, is to pick up early proximal occlusions. That is, as I said, ICA, MCA, or basilar artery occlusions have to be picked up. So what is the role of CT angiogram? As I said, to detect the vascular occlusion, you can classify them as proximal versus distal. You can also look at the vessel, look at the arch anatomy and the status of the ICA bifurcation. If there is like tight stenosis at the ICA bifurcation, it's very important for the interventionist to know, because then in that case it might be really difficult for us to go intracranially to do the thrombectomy. And so these are the common indications for CT angiogram, and also to assess collaterals. Now here is the role of CT angiogram in looking at collaterals. So as I said, look at the arch anatomy. Now in this case, there was a left MC occlusion, so we would look at the left ICA, the left common carotid origin from the arch, look at its course, look at the bifurcation. All these helps us for planning for the endovascular therapy. This is an example of a 3D volume rendered image of a difficult arch. In this case, it's a very tortuous right ICA, which is taking almost like a 90-degree turn here, acute kink. So in cases, it might be difficult for us to access, and we have to use special devices to get hold of this vessel to make it straight and then enter intracranially. So a CT angiogram is a very good picture of the vascular complexities. So when I spoke about CT angiogram in collateral imaging, I was speaking about multi-phase CT angiogram. This is not very commonly done in many centers, but now the team of ESCAPE trial are advocating use of this multi-phase CT angiogram for collateral imaging, and it is a very simple tool for assessing the collateral status of a patient. So basically, we can see if the cerebral autoregulation is at a peak, it will vasodilate the collaterals, and you will see the pile vessels filling up in the region of infarcted area or the area of ischemia. How does it work? So when you do a routine CT angiogram, you basically go from arch of aorta and cover the entire brain. Once that is done, the scanner comes back, and from the base of the skull, it takes two more acquisitions from skull base to vertex, comes back, and skull base to vertex. So basically, we are getting three phases of a CT angiogram, and that is why it is called as multi-phase CT angiogram. So from the first set of images, that is from the arch to the vertex, we get the information on aortic arch, the vessels of the neck, bifurcation, and then the intracranial circulation and the site of acute arterial occlusion, and definitely to pick up the proximal arterial occlusion. What does the other two sets of images give? These are giving us almost like a real-time picture of contrast getting into the capillary phase and into the venous phase. And that helps us to judge the collaterals of that particular area. So now these set of images, as you see, the upper three are phase 1, the second is phase 2, and the third set of images is phase 3. And the ovals what I have created is the area of the MCA which you have to look at. So if you look at the topmost if you look at the topmost set of images, you can see there is an abrupt occlusion of the left MCA, and then the number of vessels in this MCA region is reduced as compared to the right side, especially on this image, on the second image if you see. But as you go to phase 2 and phase 3, you will see that the vessels are now filling up, and the number of vessels are almost same as the contralateral side or the normal side. Why? Is because of very good collaterals in this patient. That is, the vasodilatation is at its peak, it is getting good supply from the other areas, and the collaterals have opened up, so the brain is really perfused and it is not at high risk. So this gives us a very prognostication factor. We can say that this patient has good collaterals, the chances of having a larger infarct score is very less in this patient and a better prognosis. So collateral imaging is very important. So an example of using collateral scoring, this is in a case of right MCA hyperdense sign. You can see this is the right MCA hyperdense sign with early ischemic changes. You can compare with the contralateral insular region. Insular ribbon sign is there. The M1 is in M1 area is showing hyperacute changes. So basically a score of 8 because two areas, 10 minus 2, 8 we are giving, and dense MCA sign. So good aspect score, definite proximal occlusion. What do we see next? We do the CT angiogram. This is the coronal MIP image showing acute occlusion of the terminal ICA, proximal A1 and M1. We call it as T occlusion because T-shaped vessel is occluded here. And when we do the collateral imaging, however, we see that the collaterals are really poor on this side. Though the aspect is good, we see the collaterals are really bad on the side as compared to the normal side. And as we go to phase 1 and phase 2, we see that the contrast is still stuck in the MCA level without going into the pile region. so very poor collaterals, and this patient had a bad outcome. So even though the aspect is good, the proximal occlusion is seen, bad collateral patients don't do good. This is another example of right MCA occlusion on CT angiogram. So here you can see that the collaterals are really good compared to the contralateral side. You see a lot of vessels over this side as compared to the other side. So collateral circulation is really good. So this is about multi-phase CT angiogram for assessment of collaterals, and this is being advocated by many of the clinical stroke teams now, and it would be nice that even places in India can start doing this for collateral imaging. And this has almost replaced CT perfusion because it's easy to do the interpretation, because it is more of a subjective. You can just look at it and interpret whether it is good collaterals or bad collaterals. A lot of scoring systems are coming now, but nothing in clinical use yet. Coming to CT perfusion. CT perfusion is the study of almost like the first pass of the contrast as it flows from the arterial side into the tissues and then gets washed off. So it is basically acquisition of a part of the brain, generally at the level of basal ganglia in case of acute anterior ischemic stroke. And you take at least 50 acquisitions of those limited area, and you have to track the how the bolus passes during this time. And this gives us various parameters. They are cerebral blood volume, cerebral blood flow, mean transition time, and the time to peak. So CBV, CBF, MTT, and TTP. They are the 4 parameters which you are going to study in CT perfusion. So what does CBV mean? It's the volume of blood per unit of brain tissue, and normally it is around 4 to 5 ml per 100 grams. CBF is the volume of blood flow per unit of brain tissue per minute. So it is per minute rate of flow, and as I said, it is between 50 to 60 normally. What is MTT, the mean transit time? It is a time difference between the arterial inflow and the venous outflow. So basically, this gives us the circulation time, that how much time is it taking for the contrast to pass through this tissue. And time to peak is the time from beginning of contrast injection to the maximum enhancement. So time to peak gives us almost a rough estimate of cerebral blood flow. It is from how it enters to the time where it is maximally taken by the tissue. So these are the 4 parameters which are studied in CT perfusion. So how do we interpret CT perfusion in the light of acute imaging? It is based on the hypothesis that penumbra shows either increased MTT with moderately decreased CBF and a normal or increased CBV secondary to autoregulatory mechanism. This is very, very important for all the residents to understand. How do we define a penumbra on CT perfusion? That means when the blood flow to a particular area is suddenly occluded, first thing what is going to reduce is the CBF. So obviously the area of brain with decreased perfusion, decreased CBF would be seen in the penumbra as well. But what is increased or normal is the cerebral blood volume, basically the volume of blood in that particular tissue. So because of autoregulatory mechanisms, if the collaterals open up, there is more blood volume in that particular area. So even if the CBF decreases, the CBV will try to maintain itself, and that is why it is called the penumbra. And also the MTT would be increased. But also there is another possibility that the MTT is increased with markedly reduced CBF and maybe moderately reduced CBV. That means the autoregulation is not really working well, and there could be some minimal change in the CBV as well. But an infarct score is defined as severely decreased cerebral blood flow. The cerebral blood flow will be decreased in both penumbra and infarct score. But what really important is to understand that CBV will markedly reduce in infarct score. That is, the autoregulation is not working, so the blood volume itself is also less. So this is how you differentiate between the infarct score and a penumbra. Both will show decreased CBF and increased MTT, but what is different is that the CBV is maintained in penumbra, but it is markedly reduced in infarct score. So as the cerebral blood flow goes, this is the capillary phase and this is the venule phase. So there is a formula for calculation of CBF. Basically, it is the division of CBV over MTT. So as I said, CBV, decreased CBV suggests core of the infarcted space, and decreased CBF or MTT represents penumbra. So this is very important for you to understand. This is how the CT perfusion is calculated, basically on deconvolution analysis, where the arterial input function and venous input output function are mapped. So as you see that the purple graph is from the arterial input function, and the yellow is from the arterial input function, and the purple is from the venous output function. And based on this, the computer will calculate the maps. And this is how the maps look like. So in this case, it was a left MCA territory infarct. You see that cerebral blood flow. To start with cerebral blood flow, it is reduced. You can see that these areas are blue. So the entire MCA territory is showing decreased cerebral blood flow. So this means that these are the areas at risk, but we can't be sure what is the core. So maybe we can say confidently that the penumbra is as big as this. The entire MCA territory is a penumbra. But when you go to cerebral blood volume, it is almost normal or maybe slightly increased in the region of penumbra. But there is a small area in the basal ganglia which is showing reduced CBV. So this is the core, and this is the penumbra. And there is a major mismatch between the core and the penumbra. So this gives us an idea that there is a lot of salvageable tissue here to be saved. Similarly, another example of right MCA stroke, where you can see a large area of defect in the MTT map. MTT map is almost similar to the cerebral blood flow map. You can see that the penumbra is involving the entire MCA territory. But when you go to the CBF map, there is a region of decreased CBF anteriorly and increased CBF posteriorly. So it is this region which is at risk of ischemic core, and the rest of the region is still showing good cerebral autoregulation. But what are the pitfalls of CT perfusion? First of all, it depends on the arterial and venous outflow function. So in patients who have cardiac disorders because of circulatory disorders, it will be difficult for the computer to assess the arterial function clearly. Then slide selection. And because it is done by the technicians, it's very paramount importance to teach them what is the level of interest, because sometimes they can just take few slices down or up and not really give a good picture of the MCA territory. If there are some background ischemic areas changes already going on because of small vessel ischemic disease, or in cases of seizures mimicking stroke, because those areas will also show increased CBF and CBV, or in case of vasospasm. These are the areas where the CT perfusion may not be really helpful in interpreting. So this is about CT perfusion. Going to the last modality, that is the MRI in acute ischemic stroke. What are the advantages? It's most accurate evaluation of stroke size and location, and it gives a detailed brain tissue evaluation, but it is time consuming, it's high cost, and contraindicated for some patients with pacemakers, metallic implants, and stuff like that. And it's not always available. Not all centers have it. So that is the most important thing, is it is time consuming. And as I said, time is brain. So MRI is really losing its popularity in acute stroke imaging now, at least hyperacute stroke imaging, because of this particular constraint. And the most important imaging sequence in MRI for detecting acute ischemic stroke, all of you know, is diffusion weighted imaging. What happens is there is osmotic pump failure as the first event in ischemia, and that causes a drive of the fluid from extracellular to intracellular component, and that reduces or restricts the motion of water, and so it is detected as decreased diffusion coefficient and increased restriction of diffusion. And the changes on diffusion can be seen as early as 30 minutes of the onset of stroke. And this beats the T2 signal or the flare signal by 3 to 6 hours. So it is definitely a very sensitive modality to pick up acute ischemic stroke. However, the only problem is it is time consuming, depends on patient motion, and not always available. We can also do perfusion weighted imaging in MRI. Again, very time consuming. It can be done with contrast or without contrast. The perfusion weighted imaging will give us again an idea of reduced cerebral blood flow. And diffusion weighted imaging almost always gives us the area of ischemic core. So when you differentiate the difference between or the mismatch between perfusion and diffusion weighted imaging, you get the penumbra. So again, it's a very sensitive modality, but time consuming and the interpretation is difficult. MR angiogram can be done to pick up the site of acute vascular occlusion, but as in this case, you will see that the left ICA and left ICA branches are not filling. So it is not very sensitive in picking up, but it is more vulnerable to patient motion artifact, direction of flow, and the speed of flow. If there's a slow stagnant fluid can be missed. So MRI is not very sensitive. So to conclude, there are some recommendations given by the team of experts who have been giving the guidelines for the stroke imaging. So according to them, it is the non-contrast CT. It is the first imaging modality in setting of acute stroke to rule out hemorrhage, to look for obvious extensive infarcts. MRI may only be used if centers are able to achieve the same speed and efficiency as non-contrast CT. CT angiogram should be the vascular imaging of choice to look for vascular occlusions and for planning endovascular therapy. And also consider looking at collaterals on multi-phase CT angiogram in conjunction to non-contrast CT aspect score for more reliability, because this collateral imaging actually has to correlate better with the aspect scoring, and this helps in prognostication. CT perfusion may or may not add utility in addition to non-contrast CT, CT angiogram, and CT angio collateral imaging in endovascular decision making. So it is still to be worked upon, and better protocoling for CT perfusion important. Why? Because it is difficult for the technique is difficult, processing takes time, and interpretation has to be done by experts, which may or may not be available all the time. So most of the time CT perfusion is done at our center, but it is we are able to process and interpret it at a later hours, mostly after the patient is being treated. So it is not practical to really do CT perfusion, but many centers are working on it, and many rapid protocols are coming up for easy interpretation. So remember, time is brain, all about faster reperfusion, faster imaging, faster interpretation. So acute imaging in stroke is all about time and correct knowledge of the anatomy and scoring of the infarcts. Here I end my talk. Thank you so much. Aspect score potentially delay interpretation. I think it's more about getting used to aspect scoring. It's quite quick nowadays, and to make it easier, basically we are not really sticking on to the correct score. We classify them broadly into good, moderate, and poor aspect score. So we just roughly say that anything beyond 7 is a good aspect score, and less than 7 or maybe between 4 to 7 we consider it as moderately poor, and less than 4 as very poor. So if the residents make a mistake in 1 or 2 score, it is fine. But grossly, we at least give. The residents are trained to read this aspect scoring. So it's more about getting trained. I don't believe it delays at all. Aspect scoring is a very, very helpful tool for us to go ahead and plan on the endovascular treatment. So I think it doesn't delay at all.